Now, how does that differ from diastolic heart failure? Okay, so just to run through these pieces really quick. So again, heart failure with preserved ejection fraction, right? The ejection fraction is not the issue here. High pressures are going to lead to a poor compliance, the opposite of systolic heart failure, which had a high compliance. And systolic heart failure, I can accommodate the blood, I just can't get it out of the ventricle. In diastolic heart failure, I cannot accommodate the blood, right? That's the problem. I can't accommodate large volumes of blood. Common causes here of diastolic heart failure, hypertension is the big one, especially chronic hypertension, because it's these prolonged, very high pressures that eventually lead to this remodeling of the heart that leads to this low compliance. Aortic stenosis is also very classic, right? If I have anything that's going to increase my afterload, then I need to generate higher pressures to get over that afterload. So if my heart is constantly requiring higher pressures to get through that obstruction of the aortic stenosis, that's going to increase the pressures in the left ventricle and eventually lead to remodeling, causing decreased compliance. Infiltrative disorders can also do this, and we'll talk a lot more about these in the cardiomyopathy lecture, which is next. But in general, again, same principles here. We're going to have an increased left ventricular pressure, and that pressure, usually there's some increased contractility. Just imagine, if you have aortic stenosis, you got to get past that aortic valve, right? The left ventricle is going to have to eject blood past that, so it has to contract harder. And over time, that increased pressure is going to lead to a lower compliance. Now, what we just said with systolic heart failure, right? So like I'm going back here, I'm going to look at my cross section of my left ventricle. So I'm looking at my donut of my left ventricle, right? Systolic heart failure, it would be something like this. So I'm going to add the sarcomeres in series, but the problem is in that adding them in series, right, I can accommodate more blood, so my compliance is going to go up, right? I can fit more blood in here, but guess what? I can't really do much with it, right? Because I kind of have this floppy ventricle that doesn't really have a lot of strength here. Look at how thin it is. Okay, so this is also sometimes called a dilated cardiomyopathy. Okay, so dilated cardiomyopathy in systolic heart failure. Don't confuse the D in dilated with the D in diastolic. Those are not the same thing. Dilated cardiomyopathies are seen in systolic heart failure for the reasons we just mentioned. This lumen is dilated. That's a dilated cardiomyopathy. Okay, so this is systolic heart failure. Now, how does that differ from what we're talking about right now? I'll do this one in a different color. How does that differ from diastolic heart failure? In diastolic heart failure, instead of adding those proteins in series this way, I'm going to add the proteins this way. Okay, so I'm going to thicken this thing up quite a bit. So now you can see my cavity size, and this is a pretty extreme example, but my lumen is actually quite small. So my compliance, how much blood I can hold in here for a given pressure, is going to be pretty low. But my contractility might actually be higher, right? My contractility might actually be higher potentially because I have more muscle tissue there, or the contractility eventually led to the poor compliance and remodeling, right? Chicken or the egg kind of thing. But that's what you really have to remember about diastolic heart failure. So this is going to be your diastolic heart failure. Okay, so impaired relaxation here of this ventricle from all of this muscle tissue surrounding it.